Good morning, everybody. I call this hearing to order. I request unanimous consent that the Chair is authorized to declare a recess at any time. Hearing no objections, so ordered. Today, our subcommittee is meeting both in person and remotely. I want to be clear about what makes this format possible. First, the wide availability of vaccines and boosters throughout the United States, and specifically to the members and staff of this committee. Second, the regular and continued adherence to the recommended health and safety protocols. This pandemic is by no means over, but we have reached a point where we can safely engage in person if certain practices are followed. This information previously was provided to members and staff, but I want to reiterate what the committee will require in order for members and staff to participate in this hearing in person. One, if you're unvaccinated or your vaccination status is undetermined, you must wear a mask at all times. Two, if you're unvaccinated or your vaccination status is undetermined, you must maintain physical distance within the hearing room. Three, if you are feeling unwell, you should participate in the hearing remotely. And four, members are permitted to be accompanied by one staff member while they are present in the hearing room. During the covered period declared by the Speaker pursuant to House Resolution 8, remote participation in hearings will continue to be an option for members. For those members participating remotely, if you're experiencing connectivity issues, please make sure you or your staff contact our designated technical support staff so those issues can be resolved immediately. Members participating remotely must continue to remain visible on camera for the duration of their participation in the hearing unless they experience connectivity issues or other technical problems that render the member unable to fully participate on camera. It is committee policy that members participating remotely will remain muted when not recognized, and for those in the hearing room, the policy remains the same, that only members who are recognized or seeking recognition should unmute their microphone. This is out of courtesy to all members on the committee, and so that background noise does not interfere with another member who is recognized to speak. When you are recognized, whether in the hearing room or on the remote platform, you'll need to unmute your microphone and pause for 2 to 3 seconds before speaking so that your words are captured on the live stream. Without objection, members will be recognized in order of committee seniority for questioning witnesses today. With that out of the way, I want to welcome everyone to today's Economic Opportunity Subcommittee Oversight hearing entitled Reviewing President Biden's Strategy to Reduce Veteran Suicide by Addressing Economic Risk Factors. In November, President Biden released a national strategy to reduce military and veteran suicide. Our hearing will focus on the strategy's priority goal 4, addressing upstream risk and protective factors for veteran suicide. We'll discuss how we can design policies and programs to address economic opportunity, mobility, and stability, to complement treatment for behavioral health needs as part of a comprehensive approach to prevent veteran suicide. Suicide prevention is a shared priority for this committee and the Biden-Harris administration. Chairman Takano and Health Subcommittee Chairwoman Julia Brownlee continue to do tremendous legislative and oversight work to address this need. Our subcommittee partnered with them to develop the Ensuring Veterans Smooth Transition, or EVEST Act, which passed the House with bipartisan support in January. That bill, if signed into law, would provide seamless enrollment in VA health care for eligible service members during their transition to civilian life, so they can access the suite of VA care when they need it, an important step towards preventing veteran suicide. With that said, we know there is no one single cause to suicide, and this hearing will focus on how we can reduce risk factors and strengthen protective factors against veteran suicide as they relate to economic opportunity. Much of our discussion today will center around the social determinants of health, which are the conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. Examples of social determinants of health include many of the intersectional issues within our subcommittee jurisdiction, such as safe housing, education, job opportunities, and also access to nutritious foods. It's heartbreaking to review the statistics of how these factors correlate to veteran suicide, each of which represent individual lives lost. For example, veterans who experience homelessness in their lifetime are nearly 4 times as likely as other veterans to have ever attempted suicide. One study found that food insecurity in veterans is associated with increased depression symptoms and suicidal ideation, and that this association intensifies as food insecurity worsens. The study also recommended that veterans with food insecurity be screened for depression and suicidal ideation, and that simultaneously depression treatment plans and suicide prevention programs should consider basic needs like food security. In terms of foundational financial well-being, a study showed that raising the minimum wage by as little as $1 can decrease the suicide rate. Further, both justice-involved individuals and veterans are at elevated risk for suicide. But research examining the intersection between justice involvement and veteran status has been limited. So today we'll discuss how a comprehensive approach to reducing veteran suicide must include a focus on these risk factors and social determinants of health to be effective. The Biden-Harris administration's strategy makes clear that cross-cutting agency collaboration is key to implementing a public health approach to mitigate the risks associated with veteran suicide. That's why we're so pleased to have 4 federal agencies with us today on our first panel: the Department of Veterans Affairs, the Department of Labor, the Department of Housing and Urban Development, and the Centers for Disease Control and Prevention. Really great to see you all here today. But the work to prevent veteran suicide does not fall on these agencies alone. It requires a shared commitment from policymakers, veteran service organizations, scientists, researchers, advocates, families, caregivers, survivors, and loved ones, many of whom are represented here today on our second panel. I'm eager to hear how each organization is coordinating their efforts in furtherance of the administration's strategy to reduce veteran suicide. Finally, I want to encourage everyone listening, veterans, family members, caregivers, friends, and colleagues, to save the Veterans Crisis Line number in your phones in case you or someone you care needs it. It's 1-800-273-8255. That number again is 1-800-273-8255. The Veterans Crisis Line is a vital resource that provides free, confidential support and crisis intervention, and it's available 24 hours a day, 7 days a week, 365 days a year. I'm ready to dive into this discussion with our witnesses, so I'll conclude my comments there and recognize my friend, the ranking member, for any opening remarks he may wish to make.
Thank you, Mr. Chairman. I thank you for holding this oversight hearing on economic risk factors for veteran suicide. While progress has been made in the last few years, the United States is still an active epidemic of death by suicide. These tragic actions disrupt families and can shatter lives. We know that stressors on all Americans are growing, and veterans are not immune to this. In my home state of Alabama, we have a proud military tradition, with more than 9% of our citizens having served our country. Unfortunately, the veteran suicide rate is even higher in Alabama than the national average, and certainly significantly higher than the national civilian average. To address this epidemic, the Alabama Department of Veterans Affairs created an Alabama's Challenge Initiative, which is aimed at combating the stigma veterans face with mental health, in addition to providing information about suicide, employment opportunities, and mental health resources. I was honored to attend the first of these Alabama Challenges statewide. They toured the place, came to my district actually in Dothan, Alabama. It was great to see so many people come together with a common goal of supporting veterans and their families while providing veterans with a job fair and other valuable resources. Too often, we view improving mental health as a tool in our toolbox for preventing veteran suicide. That is simply not the case. I am glad that we're here today to look at economic risk factors, as it is important to ensure that we work to eliminate stressors on veterans related to housing, unemployment, hunger, and self-worth. While veteran unemployment has decreased to the pre-pandemic levels that were achieved during the Trump administration, it does not tell the whole story. We all know that the Biden economic agenda has forced millions of Americans to tighten their belts as inflation continues to rise unabated. From the gas pump to the grocery store, veterans and their families are feeling the same pain. To combat this burden, VA, labor, and other agencies will need to re-examine every economic program they administer to ensure that they are meeting the needs of veterans. I'm looking forward to hearing from the VA about their implementation of the transition and employment provisions from the Isaacson-Roe legislation that was signed into law by Congress last year, as well as other programs that will promote economic security for veterans. I was disappointed in testimony from some of the federal agencies on the first panel. Their written statements read more like a regurgitation of the programs that offer and promise collaboration through interagency working groups. We need more than promises and work groups if we are truly going to get a handle on this pandemic and to save veterans' lives. It was disappointing to me that these written statements said very little about whether these programs and work groups actually prevent suicide. More emphasis must be placed on collecting meaningful data from these programs and holding them accountable for improving outcomes so we can ensure that we are not just sending good money after bad. While it is certainly worthwhile to conduct oversight on programs that can improve economic worth and prevent suicide, I do want to make sure that we strike the right balance and avoid perpetuating the broken veteran narrative. We know veterans have lower rates of unemployment and are more successful in higher education than non-veterans. They truly are the best this nation has. They are not ticking time bombs, as we portray them to be sometimes. Nonetheless, it is critical that we do what we can to reduce the stigma of veterans standing up and asking for help, regardless of if it is for their mental health or for their finances. It is really okay not to be okay. I want to tell a quick story. A few weeks ago, actually in my district office in Dothan, Alabama, we had a veteran come in the front door and he said, I was hearing voices. He said they were telling me to kill people. So he was having a mental breakdown. And he came into my office. He said he felt in his spirit to come to my office, to Congressman Barry Moore's office, and ask for help. We, as leaders in our community, need to be available to our veterans, but we need to encourage you to do the same. So with that, Mr. Chairman, I want to go ahead and I'm going to hand out this veteran suicide number one more time. I don't think we can ever do that too much, right? So please, if you're struggling, call 1-800-273-8255 and press 1. You can also text 838-255. And with that, Mr. Chairman, I'll yield back.
I thank the ranking member for his comments. Certainly agree that our veterans are the very best of us. We need to do everything we can to serve them. As I mentioned earlier, for our first panel today, we're going to hear from 4 federal agencies. So I'd like to welcome our 4 guests this morning. First, Dr. Susan Black, the National Suicide Prevention Officer for the Veterans Benefits Administration. Thank you for joining us. Dr. Black is accompanied virtually by Dr. Matthew Miller. Hello, Dr. Miller, Executive Director for Suicide Prevention for the Department of Veterans Affairs. Also joining us is Dr. Christopher Jones, Acting Director of the National Center for Injury Prevention and Control at the Centers for Disease Control and Prevention. Thank you for joining us. Next, we're welcoming Ms. Peggy Bailey, Senior Advisor to the Secretary of the Department of Housing and Urban Development. Thank you for being here. Finally, we have Mr. James Rodriguez, Assistant Secretary for the Department of Labor's Veterans Employment and Training Service, also known as DOL Vets. Good to see you again, Mr. Rodriguez. Thanks for joining us. Dr. Black, we'll begin with you. You're now recognized for 5 minutes.
Thank you, sir. Chairman Levin, Ranking Member Moore, and members of the subcommittee, thank you for this opportunity to testify today about reducing military and veteran suicide by addressing economic factors. I am accompanied today by Dr. Matthew Miller, Executive Director, VA Suicide Prevention, and Acting Executive Director, Prevents, President's Roadmap to Empower Veterans and End a National Tragedy of Suicide. I want to express my appreciation for your continued support of our nation's veterans, their families, caregivers, and survivors. Secretary McDonough has defined his 4 guiding principles as advocacy, access, outcomes, and excellence to be the foundation of serving veterans and their families. This sacred mission is both personal and professional for me, and it is my honor to serve veterans, their families, caregivers, and survivors. In 2019, 45,861 adult Americans died by suicide. Of those, 6,261 were veterans. These numbers are more than statistics. They reflect individual lives ended before their full stories were written. With each loss, we rededicate our commitment to the mission to address suicide as a national public health concern. Suicide is a complex issue with no single cause. Multiple studies have demonstrated that factors related to economic well-being, such as financial literacy and security, educational, vocational development opportunities, and vocational stability can reduce the risk of suicide. The Veteran Benefits Administration provides a variety of benefits and services upstream which can help reduce or eliminate economic risk factors associated with suicide and promote protected factors for veterans. VA research shows that the first year following discharge from active duty service may pose significant challenges, including homelessness, family reintegration, unemployment or underemployment, post-traumatic stress disorder, and substance abuse, all of which can increase the risk for suicide. VA is committed to ensuring today's service members are appropriately and adequately prepared to transition to civilian life and seek a meaningful post-military career with established post-military support. Launched in 1991 and refined by the Veterans Opportunity to Work to Hire Heroes Act of 2011, the Transition Assistance Program is an interagency effort designed to help the approximately 200,000 service members who separate annually successfully transition to civilian life. VA acknowledges that the first year of transition out of military service is crucial for transitioning service members. It is with this thought in mind that VA created the VA Solid Start program that attempts to connect with recently separated veterans at 3 key points during the critical first year of military to civilian transition. The program focuses on specific needs of each recently separated veteran. VA Solid Start is committed to helping all recently separated veterans establish a relationship with VA, increase the awareness of available VA benefits and services, lower any barriers of entry into VA mental health services, and support their successful transition into civilian life. In fiscal year 2021, VA Solid Start successfully connected with more than 149,000 veterans. VA understands that economic well-being and financial literacy for the veteran community require stakeholders from across veteran ecosystems to come together to improve opportunities as well as long-term economic sustainability. To meet this need, VA launched economic development initiatives which connect service members, veterans, and family members to VA benefits, economic information, partners, services, and tools they need in economically distressed regions. Furthermore, in 2020, VA and Prudential Financial entered into a partnership to provide financial literacy and wellness to participants. Prudential agreed to give financial literacy classes on the third Wednesday of each month at no charge to VA or the veteran. The Wednesday Financial Education Series has taken the financial questions of our veteran community and created a platform for financial literacy. VA supports the President's strategy for reducing military and veteran suicide and will continue to work to achieve the goals within the strategy. VA will remain dedicated to collaborating to promote economic well-being and addressing upstream issues and protective factors that increase the risk of suicide. Chairman Levin, Ranking Member Moore, this concludes my testimony. I am happy to respond to any questions you or the committee may have.
Thank you, Dr. Black. Dr. Jones will now recognize you for 5 minutes.
Thank you. Thank you, Chairman Levin, Ranking Member Moore, and distinguished members of the committee. It's an honor to appear before you today to discuss the Centers for Disease Control and Prevention's ongoing response to suicide and how we leverage that work to protect populations most at risk, including our nation's veterans. Thank you to the chairman and the committee for your ongoing support of this important priority. Suicide remains a leading cause of death in the United States, and it's the second leading cause among people ages 10 to 14 and 25 to 34, and among the top 9 leading causes among adults aged 35 to 64. In 2020, nearly 46,000 lives were lost to suicide, and many millions more thought about, planned, or attempted suicide. Fortunately, we know suicide is preventable, not inevitable, and CDC's vision for suicide is clear: no lives lost to suicide. And while anyone can experience suicide risk, certain groups are at substantially higher risk, including veterans. Tragically, 1 out of every 7 lives lost to suicide in the U.S. in 2019 were veterans, most commonly veterans not engaged in VHA care. And for over a decade, suicide rates among veterans were higher and rising faster than the non-veteran U.S. population. But there are prevention actions that we can all take that can have profound and lasting impacts for both veterans and non-veterans. And among veterans and non-veterans, mental health challenges and substance use are well-documented contributors to suicide risk. But CDC research shows that suicide has no single cause and is influenced by a range of factors at the individual, relationship, and community levels. For example, economic and housing insecurity, social isolation, relationship problems, and other stressors in the home or community also play an important role. CDC recognizes the important connections between suicide, substance use, and adverse childhood experiences, or ACEs, which are traumatic events that happen during childhood. In fact, ACEs are common among veterans who attempt suicide, with a recent study showing that ACEs were the second strongest factor differentiating veterans who attempted suicide from those with suicidal ideation but no attempt. So while suicide, overdose, and ACEs may be viewed as independent challenges, there are also consequences of shared root causes that can be prevented by upstream prevention strategies. Incorporating this holistic perspective is critical as we work to prevent suicide. CDC's comprehensive approach to suicide prevention focuses on engaging multiple sectors, including healthcare, jobs, housing, education, and others, to advance collaborative efforts that operate upstream to stop risk in the first place, while also addressing the needs of people at risk by connecting them to services and supports. CDC's Comprehensive Suicide Prevention Program, first initiated in 2019, currently funds 11 recipients to implement this public health approach to suicide prevention. Funded states track fatal and non-fatal suicide data, implement prevention strategies from CDC's resource of evidence-based interventions, and partner with health and community organizations to reach those who need support the most. 5 of our 11 funded jurisdictions have identified veterans as a specific focus population. For example, Louisiana is training veteran leaders to identify and provide support to peers at increased risk. And North Carolina is teaching healthcare providers to identify suicide risk in veterans and counsel them on safe storage of lethal means like medications and firearms. And with the additional funding appropriated to CDC for our suicide work in fiscal year 22, we'll be able to expand this program to 6 additional jurisdictions. In addition, we know most veterans who die by suicide are not engaged in VHA care and depend on community resources. To better understand suicide among this population, in 2017, CDC launched an initiative that focused on engaging with veteran-serving organizations, or VSOs, that are able to reach veterans not otherwise engaged in services or supports. To advance this work, CDC and the CDC Foundation are collaborating and providing funding to 14 VSOs to implement and evaluate upstream prevention approaches like providing social support, connecting veterans to their communities, and linking those at acute risk to services, modeling the type of interagency collaboration necessary to tackle such a complex problem. CDC also has ongoing collaborations with DoD and VA to strengthen suicide-related data. For example, we've linked DoD's suicide event report data with CDC's National Violent Death Reporting System to create a detailed picture of the unique characteristics of veteran and active duty suicides. Every life lost to suicide is a tragedy, and for far too long, veterans have experienced a disproportionate impact. We must do all we can to address this urgent issue, and CDC is committed to using data, science, action, and collaboration to advance this work as part of a whole-of-government approach. Thank you for the opportunity to speak, and I look forward to your questions.
Thank you, Dr. Jones. Ms. Bailey, you're now recognized for 5 minutes.
Thank you. Good morning, Mr. Chairman and Ranking Member Moore and distinguished members of the subcommittee. Thank you for providing the Department of Housing and Urban Development the chance to the opportunity to testify on this important topic of reducing suicides among veterans. I ask that my full written previously submitted testimony be submitted into the record. Secretary Fudge takes this issue quite seriously and is alarmed by the fact that so many veterans experience housing insecurity, which contributes to increased risk of suicide. Unstably housed veterans have more than double the rate of suicide compared to stably housed veterans. In addition, 29% of veterans receiving treatment are being at high risk of suicide had evidence of housing instability. Data on over 36,000 U.S. adults in the National Epidemiological Study of Alcohol and Related Conditions 3 found that U.S. veterans with homeless histories were 7.8 times more likely to have attempted suicide than veterans with no homeless histories. While homelessness among veterans has decreased by nearly 50% since 2010, there are still an estimated 37,000 veterans on any given night and many more who experience homelessness over the course of the year. Beyond literal homelessness, the most recent available data from the American Housing Survey shows that there are 619,000 renter households with at least one member who served in the military who experience what HUD refers to as worst-case housing needs, meaning that they have very low incomes at or below 50% of area median income and either had a housing cost burden of 50% or greater, lived in severely inadequate housing, or both. That translates to 15% of all renter households with a former service member experiencing worst-case housing needs. Roughly speaking, this means that there could be at least 700,000 veterans every year who experience housing insecurity or homelessness and who are therefore at heightened risk of suicide. We know HUD programs can reduce homelessness and housing instability. The HUD VA Supportive Housing, or HUD-VASH program, contributed substantially to the nearly 50% reduction since 2010 in homelessness among veterans. This successful intervention with interagency collaboration has been demonstrated to be cost-effective in helping high-need veterans permanently exit homelessness and reducing their use of other costly services such as inpatient hospitalizations, emergency departments, jails, and detox programs. HUD-VASH has also made it possible for 82 communities in 3 states, Connecticut, Delaware, and Virginia, to determine that they have effectively ended homelessness among veterans. HUD also continues to work with the Department of Veterans Affairs and the United States Interagency Council on Homelessness to end veterans' homelessness through the joint strategies we have developed at the charge of Secretary Fudge and Secretary McDonough. HUD is also supporting VA's goal to place 38,000 homeless veterans into permanent housing by the end of 2022. We are largely doing this through targeted technical assistance to places with low utilization rates of HUD-VASH vouchers, but high rates of veterans experiencing homelessness. The problem with housing instability among veterans isn't solely one for veterans experiencing homelessness and with high needs for VA services. Many veterans work hard every day, but in jobs with low incomes, which makes it difficult to afford housing. That struggle can impact their mental health. Therefore, HUD and other state and local partners use our broader assistance programs targeted to low and extremely low income households to serve veterans as well. All of our programs, homelessness, public health, housing choice vouchers, multifamily programs, the home ownership assistance, mortgage lending, and housing counseling serve veterans with low incomes. In addition to tackling housing affordability and housing insecurity, HUD is also working to ensure that our national network of frontline housing professionals are able to catch signs and symptoms of mental health distress and refer people to care. Mental health first aid training, for example, is an evidence-based training designed for non-clinical personnel such as first responders, law enforcement officers, teachers, and others to recognize when people are experiencing mental health symptoms. HUD is in process of extending that type of training to our national network of housing providers and service coordinators. In closing, HUD shares the subcommittee's goal to reduce housing insecurity as a risk factor for suicide among veterans and ensure that whenever a veteran does experience housing insecurity or homelessness, our network of housing agencies and their staff are able to recognize those signs of distress and suicide ideation and create and connect people to care. We hope members of the subcommittee will also support the President's budget requests that will enable us to achieve this goal. Thank you for the opportunity to testify.
Thank you, Ms. Bailey. Mr. Rodriguez, you're now recognized for 5 minutes.
Chairman Levin, Ranking Member Moore, and distinguished members of the subcommittee, on behalf of the Department of Labor, I want to thank you for the opportunity to appear today to discuss how DOL Veterans Employment and Training Service supports the whole-of-government approach to reduce veteran suicide. Death by suicide is a tragedy that impacts entire families and communities. VETS recognizes that employment is a critical factor to reduce veteran suicide because meaningful careers facilitate social connectedness, sense of purpose, and financial stability. With VETS' focus on economic well-being, we are dedicated to doing our part to make sure our nation's veterans and their families have the support they need to thrive and prosper. VETS is also committed to active engagement in these collaborative efforts to ensure that our veteran community and their families have awareness of and access to the wide array of services to support their overall well-being. At VETS, we understand no federal agency can operate alone in this ecosystem. And I'm constantly impressed with the integration and partnerships that VETS has established and continues to develop at the federal, local, state, and national levels under the leadership of this administration. VETS is working with other interagency partners to take all necessary actions to reduce veteran suicide while keeping our veterans, transitioning service members, and their families in the forefront and their economic prospects intact. In 2012, Executive Order 13625, improving access to mental health services for veterans, service members, and military families, formed the Interagency Task Force, or ITF, on military and veterans' mental health. The ITF has a primary goal of coordinating and supporting interagency programs and activities related to mental health, suicide prevention, substance abuse, and expanding access to mental health care. As I co-chair the Evidence-Based Treatment Access and Engagement Work Group, we are tasked with evaluating access and engagement barriers to evidence-based mental health care for service members, veterans, and their families at elevated risk of suicide. We are collaborating with federal agencies to produce a report on actions taken to improve access to mental health care, along with additional recommendations for future action. In addition to the Interagency Task Force collaborative efforts, VETS, as a DOL representative, participates in the Transition Assistance Program Executive Council, often known as the TAP-EC. The TAP-EC is continuing its efforts to identify and expand mental health touchpoints while implementing procedures for data exchange and conducting warm handoffs of high-risk transitioning service members. Beyond the military to civilian transition, DOL provides services to veterans and their families anytime they need support for the rest of their lives. These services are provided through the workforce system and the network of approximately 2,400 American Job Centers authorized under the Workforce Innovation and Opportunity Act, or WIOA, and overseen by DOL's Employment and Training Administration. AJCs provide a full range of assistance to job seekers under one roof, including training referrals, career counseling, job listings, and similar employment-related services. Veterans and eligible spouses receive priority of service for all DOL-funded job training programs, and veterans and their family members can obtain services by visiting an AJC in person or connecting to the center's information online system or through kiosk remote access. VETS looks forward to working with the subcommittee to reduce veteran suicide by ensuring that our transitioning service members, veterans, and military spouses can overcome economic risk factors. Mr. Chairman, Ranking Member Moore, thank you again for the opportunity to highlight the important work VETS is doing to generate opportunities for all veterans to have a good career with opportunity for advancement, economic prosperity, and health security. And I'm happy to answer any questions that you may have.
Thank you, Mr. Rodriguez. With that, I'll recognize myself for 5 minutes to begin the question portion of the hearing. And Dr. Black, I'll begin with you. I was glad to learn about your role as the Veterans Benefits Administration's National Suicide Prevention Officer and your task of ensuring integration between VBA and VHA. Can you or Dr. Miller please talk through how VA shares data across its sub-agencies pertaining to the risk factors of veteran suicide? For example, if a veteran falls behind on their VA home loan mortgage payments, that could signal financial troubles in their life that may exacerbate mental health issues. So how does VBA flag those indicators for VHA clinical staff?
And sir, thank you for that question. When we're looking at our veteran population and working with our integration with VHA, in Office of Mental Health and Suicide Prevention, we realized from the Veterans Benefit Administration that that we do have data that could be of benefit. So looking at the services that our veterans are actually receiving, looking at some of just some of the conditions that they're receiving benefits for can be very important when it comes to sharing data. So what we have with the VHA and VBA, we have a data sharing. We share data, and so that's that integration that we have.
But could you speak specifically to the example that I brought up? So let's say somebody falls behind in their home loan payments. That could indicate financial trouble, that could indicate mental health issues. How does VBA specifically flag something like that for VHA?
Okay, so we have shared data, specific data with VHA, with individuals who had been flagged, and that was a data sharing agreement that we had, and
But how do you do it?
That we can do. So what we do is we work with our loan guarantee. And we're looking at those veterans who may be in loan foreclosure, and so we work very diligently with loan foreclosure avoidance. Our LGY will flag, or our loan guarantee staff have this information available, and we'll flag that information. We'll see that, and then coordinating that data with our VHA counterparts and letting them know, especially if there is someone who is seen as high risk in those situations.
As defined by what?
As defined by individuals who are actually seen on our VHA mental health, and can also have what we see as indicators or could be impossible loan foreclosures. Also looking at anyone who could be in debt, having a financial debt. Those are some flags that we have.
And does somebody from VBA pick the phone up and call somebody at VHA? Is there a...
It's shared through data. And so we have data
What does
that we're
that mean?
sharing as far as those
Not
individuals.
shared through humans?
Well, it's shared, yes, sir. It is shared through humans, but it's also when we have those indicators and we see that individuals could be in foreclosure, we make those connections with our VHA counterpart.
Okay. You actually pick the phone up and call?
It's through data sharing.
Okay, if you don't, you should. Somebody should actually pick the phone up and call. Ms. Bailey, I'll turn to you. You mentioned in your testimony that HUD is providing targeted technical assistance to places that have a low HUD-VASH voucher utilization rate. Something really important to me. We've worked at this since I've been in Congress. Can you discuss the effort in greater detail, and specifically, are you providing technical assistance to public housing agencies, VA case managers, or both? And what does this technical assistance involve? What improvements have come out of it so far? We're really trying to figure out this underutilization situation. We've passed legislation here, and it is increasingly frustrating to see that that legislation is not being taken advantage of by the relevant agencies.
So thank you, Mr. Chairman. So that assistance is joint with the VA. So we have a dashboard where we can track voucher utilization across the board, but also the HUD-VASH program, and then target headquarters staff along with field staff to go to that community and figure out where the barriers exist. But the key thing that we're about to do is go through a reallocation, because one of the issues is there's a mismatch of where vouchers are sitting and where there's need. And this reallocation notice should be coming out in the next few weeks. It will be a voluntary reallocation, so places that are recognizing, look, we are not using our vouchers well, we don't have the veterans here, we've served the veterans that we can serve through the VASH program. We're going to voluntarily return our vouchers back to HUD so that we can reallocate them to the places with high need.
Okay, and same question as before. Does HUD actually pick the phone up and call the relevant public housing agencies or the relevant folks at VA to make sure that there's, not just sharing of data, but just actual
Not only
communication?
pick up the phone, but we show up at their
Good.
door.
Even better. What a concept. So I have more questions, but I'm going to hold there to provide my colleagues with their time, and then I'll come back. So with that, I'll recognize the ranking member.
Thank you, Mr. Chairman. Dr. Black, I'm very pleased that the VA is continuing to contact recently separated service members to check on them and provide information on benefits through the VA's Solid Start program. What has been the response rate of these calls, and how many are backlogged?
And sir, thank you for that question. When we're looking at our VA Solid Start and the connections, our 75% of calls are made with our what we consider priority calls, and these are individuals who had a mental health appointment within their last year of being in active duty. We have made over 200,000 calls at about a 64% rate of calls with individuals from VA Solid Start.
So 64%, do y'all normally just call a cell number to check on them? Is that how does that work normally?
So yes, so as our service members are transitioning out and going through the transition assistance program, we do let them know that there will be a call that'll occur for them. And so they're expecting that call. We tell them, hey, you're going to get a call from VA.
Save this number in your phone.
Save this number in your phone, and then we would make 7 attempts between the 0 and 90-day points. So it's 3 different points of time that we make those calls, and we'll make 7 attempts to reach those individuals. And so, but they know we're calling.
Gotcha, and then just leave a voicemail if you don't get a live person, I guess?
Yes, we'll leave a voicemail. We'll try, as I said, we'll try and make several attempts to reach that individual.
Okay, and this is just on a separate side note, Ms. Bailey and Dr. Black, kind of for both of you guys. Can y'all please provide us information on the administration's plan to permanently house 38,000 homeless veterans by the end of the year?
Sure, so I can take that one. It's the reallocation of the HUD-VASH vouchers is the primary way that we're going to do that, because that's about the number of vouchers that we have out in the world. So to be able to reallocate those to the places that have need and house people as quickly as possible. The other way that we can do that is through our mainstream housing voucher program, making sure that the great thing about the housing authorities, they're able to prioritize certain populations, and veterans are among the most are among the populations that are most often prioritized. So leaning into that prioritization for the veterans who may not need the level of care that comes with HUD-VASH, but need the financial assistance to help stabilize their housing, those are the two primary ways that we can do that, along with VA technical assistance to the case managers to make sure they're identifying people, building those relationships of trust, and connecting them to the housing providers.
So you're able to identify the veteran. Are you able to find housing? I mean, I know inventories are low right now. Are y'all struggling finding people to take the vouchers to move the veterans in?
We are, but we also have efforts underway to address that. Primarily using landlord incentives to engage landlords in the program, having landlord financial pools that help them make minor improvements to their properties, pay security deposits, things like that, that make it faster to serve someone, but also make it advantageous for the landlord to engage with HUD programs. So that's one of the primary things that we're doing. We're also looking at how we can raise the value of the voucher to meet the increasing housing costs.
Yeah, we're seeing increased costs across the board on construction, and like I said, inventory is still a little low, so I was wondering if you were having trouble. So with that, Mr. Chairman, I'll yield back.
Thank the ranking member, and I'd like to recognize my friend from New Hampshire, Mr. Pappas, for 5 minutes.
Well, thanks very much, Mr. Chairman. Thank you to the ranking member as well for holding this session. Dr. Black, maybe I could start with you and just follow up on some of the conversation you were having around the Solid Start program. Could you talk about ways that VA is considering strengthening this program to make sure these calls are as effective as possible? And in addition to that, was curious, why VA doesn't screen veterans during these calls specifically for housing and food insecurity when, as we know with this discussion here today, these are social determinants of health that affect outcomes.
And sir, thank you for that question. When we're looking at our VA Solid Start and the engagement that we have, reaching out to each individual veteran individually, the conversation is driven by what's needed by our veteran when we call them. So we do look at all of these, the risk factors. We ensure that when you're making that transition, that you have adequate housing. If employment is an issue or education is an issue that they're considering, that's a top priority for them, that's exactly what we do. So when you're looking at Solid Start, it's the veteran that's leading that conversation. It's the veteran that's leading what is important to them at that particular time. So that is something that happens during those calls. And we do follow up. After that conversation, there is an email that's sent that goes over everything that was discussed during that session, with links to any resources, with an opportunity if they need to re-engage with that Solid Start counselor who reached out to them. So that is some of those things. Looking at what we're looking at, some of the things that we're looking at moving forward with the Solid Start program is actually having an opportunity to schedule a certain time for our veterans to actually be able to call us. And so we're reaching out to them, but we're looking at an opportunity to have a specific time in which we can call them and have that engagement. We're also looking at the opportunity to use text messaging in this platform as well.
I was going to ask specifically about text. I'm glad you addressed that. And look, as you know, and as you said, this is such an important moment in time for the veteran, and to improve this process, to make sure that VA is communicating as effectively as possible and hearing the veteran. taking steps to be able to provide the best care and benefits possible for that veteran. It's just really crucial. So I hope you'll continue to look at ways to improve that warm handoff, so to speak. I just wanted to address one other issue. The department has taken some important steps forward under Secretary McDonough when it comes to LGBTQ veterans. We know that more work needs to be done to always make VA the most welcoming place possible for veterans, ensuring that it's a culturally competent institution that's capable of meeting the needs of veterans. And so I'm wondering if you can address how VA is working with DoD to ensure that adequate outreach is being done for veterans who are deserving of discharge upgrades. We know that LGBTQ plus veterans are particularly vulnerable when it comes to mental health and suicide. And so I'm just curious, as this new policy has rolled out to connect veterans to benefits and care, what's being done for that community in particular.
And thank you, sir, and thank you for that question. We do know from our VA research that the LGBTQ plus population, is at risk when it comes to suicide. We know that there's a higher risk for that. So, in looking at the VBA side of the house, we do have our outreach program that look at LGBTQ plus as that special emphasis program. So making that connection and reaching out, providing that outreach service to the population is what we're providing for them. I would like to defer to my colleague, Dr. Miller, because I think there's some things that they're also doing on the VHA side of the house as well.
Thank you, Dr. Black. I appreciate that. And I'll keep my answer brief in light of the time. I think it starts with data on our side, ensuring that we have accurate data regarding the population and the people. Therefore, we've added in FY22 to our strategic plan coordination with the program office and subject matter experts in this area for improving and supporting data gathering at the front line level so that we're better than able to engage outreach and more accurately do so. It's a first step. It's not a final step. We have some territory and road to cover here, but making sure that the information coming in represents the population and the person, and then we can engage the outreach is an important first step. Thank you.
Well, thank you, Drs. Miller and Black, and I yield back my time.
I thank my friend from New Hampshire, and I'll recognize the gentleman from Maryland, Representative Trone, for 5 minutes.
Good morning, Mr. Chairman. Thanks for holding this hearing. This is an issue which we've been focused on, mental health section area, for quite a while. Dr. Jones, a common theme we've heard from our witnesses, there's no single cause to suicide. Many psychosocial factors create a crisis, in the veteran's life. Could you talk a little bit about how CDC collects and analyzes the data related to the veterans' financial situations or other social determinants of health that may increase their risk of suicide? And does the CDC have suggestions on how the VA and other agencies can glean information about the risk factors you've spoken about today for those vets, for those veterans who are not directly connected ongoing with VA services?
Sure. Thank you very much for the question. I think there are a couple of avenues where we are trying to improve data and have made significant advancements in data collection and understanding of suicide risk generally, and also specifically to individuals who have served. So first is our National Violent Death Reporting System, which is a system that collects detailed, rich information on the circumstances and context of violent deaths, including suicide. And that has been very foundational in much of what has been shared today to talk about the risk factors beyond mental health, like social determinants, like relationship problems, substance use, other economic stressors as a risk factor for suicide. And we've published on that data routinely identifying the various contributors to suicide risk. NVDRS does capture whether or not an individual has ever served. So it has been a resource for us to look at that rich contextual data from medical examiners, coroners, law enforcement, and toxicology data to better understand the circumstances surrounding the suicide death. As I mentioned in my opening remarks, we also have been working with DoD to link their data system to NVDRS, because that then allows us to further disentangle individuals who are active duty versus veterans so that we can look at the unique characteristics of those deaths. And that has been an effort that has been underway over the last couple of years, and we've linked over 1,000 records already. So that is a resource that is coming online that I think will further help the interagency work that's happening. The other place where we are actively engaged, and this is a conversation that Dr. Miller and I have often, is linking CDC's National Death Index data, which is based on the census of death certificates in the United States, linking that to VA data, which then allows all of the other VBA, VHA, other rich data from VA to build a better understanding of what's going on with veterans who have died by suicide. And that has been an effort over multiple years. We're continuing to work to make that more timely so that the VA has access to more timely data and understanding what is going on, how trends are changing, and identify risk factors. So we're certainly committed partners in leveraging all of the data that we have to address the issue of veteran suicide.
That's excellent. Data is the key, and that analysis is what's going to get us better practices. Ms. Bailey, you stated the vets have a history of homelessness 7.8 times more likely to have attempted suicide than vets with no history homelessness. How does HUD identify and engage those vets who may be at risk for homelessness before a crisis point? And additionally, how does HUD ensure that all vets served in its programs are connected with mental health care that our vets need to thrive?
So thank you for that question. So, you know, it is difficult for us to catch folks before they enter into the homelessness system, right? The way that our structures are designed. So the way that we work on at-risk pieces is to connect with the other services and supports programs throughout the community and make sure that the housing world and the social services worlds are connected. And the HUD VASH program has really helped us do that by connecting with the VA so that and helping the VA be the signaler of people who may be housed but are on the precipice of homelessness, and being able to connect them with the homelessness or housing system to get access to care. One of the things that we've learned from the pandemic is how to do eviction prevention better, because we've been full resourced to be able to give people assistance if they're at risk of losing their housing.
Thank you. Yield back, Mr. Chairman.
Thank the gentleman from Maryland. A few more questions, and I believe the ranking member might have a couple as well. Mr. Rodriguez, the President's strategy tasks DOL vets with consulting and coordinating with the VA and DoD to create a report regarding veteran employment trends, issues, barriers, and recommendations with a specific focus on understanding opportunities for addressing economic risk factors for suicide prevention. Can you please describe the status of this effort, and does DOL have any initial findings it can share with the committee?
Mr. Chairman, thanks for that question. And one of the things that we are doing is working closely, as you mentioned, with the VA to identify some of those risk factors. We're looking at specific data points that show where some of our veterans are within the employment arena, where they are and where they are not, I should say. For example, looking at underserved communities, where veterans are not receiving resources that we currently have in those underserved communities, as well as where are the gaps in resources in those underserved communities. One of the things we're also looking at is some of the economic risk factors associated with lack of employment. Understanding that it does cause a challenge for veterans who are not employed when they make that transition initially out of the military. We're taking that data that's part of the transition assistance program. We're looking at data from that as part of our participation in TAP Executive Council. working with our partners through that council, and understanding where we can have better touch points for our veterans when they're making the transition out of the military and then when they are in the veteran status.
Thank you for sharing all of that, and that all sounds encouraging. When can we expect the report that the President's strategy calls for?
That report is due in July, and right now we are on track to have that report completed.
Thank you. By the end of July, beginning of July?
End of July.
End of July. All right, we'll look forward to reading that report. Dr. Jones, as I mentioned earlier, research examining the intersection between justice involvement and veteran status has been pretty limited. In addition, factors which drive risk for suicidal self-directed violence among justice-involved veterans remain understudied. Does the CDC have any plans to work with the other agencies to collect or analyze data related to justice involvement as a risk factor for veteran suicide?
Thank you for the question. I think we continue to focus our suicide work on populations that are disproportionately impacted, including criminal justice involved and the other populations that I mentioned earlier. I think through our National Violent Death Reporting System, as well as through our Comprehensive Suicide Prevention Program, we continue to improve data collection to identify risk populations, and in particular, where there are transition risks, such as reentry, such as transitioning from active duty to veteran status. So I think that is part of our ongoing work, is to improve the data collection to be able to fine-tune what are the risk factors and what is the intersection between the various risk factors, as no doubt individuals involved in the criminal justice situation also have challenges with finding stable housing, jobs, economic opportunity as well. And so having those data variables together certainly allow us to have a richer understanding of what's going on. I think to the extent that we have ongoing data sharing work with our VA and DoD colleagues, those are conversations we could have about information that they may have on criminal justice involvement that might be helpful, or that we may have that could be helpful to their efforts.
Terrific. Can you commit to doing that today, looking at criminal justice system involvement as a risk factor and doing better with regard to data? And
Yes.
Yes? Excellent. All right. The last thing I'll say, and it's a very parochial concern, is in San Diego County, where I represent, there's a HUD-VASH underutilization issue. So I want to take you up on your prior statement to work specifically with communities across the country, because for me, if it's not 100%, we'd like to get it as close as possible. And I know there are specific concerns to every area of the country, but nonetheless, I'd love to follow up and work with HUD on that as we try to be one of those communities that can get as close to a zero net effective veteran homelessness as possible. So I thank you all very, very much for the work that you're doing. I'll turn it over to the ranking member for additional questions.
Thank you, Mr. Chairman. Secretary Rodriguez, how do vets track program performance of staff funded under the Jobs of Veterans State Grant Program? Is there any direct way to know if the services provided by these staff led to a veteran becoming employed? These state grant programs, I should say.
Congressman, the states actually report these to us, and each state has their own specific mandatory requirements, and so they have statistics that they report to us, and we utilize that to understand how the grant's being utilized, how it's being used to support the veterans in their states. So we receive that data from the states. They develop their own measurements, and we work closely with them to ensure that those measurements are meeting the needs of the veterans in each state.
Off the top of your head, any states doing really, really good at this, doing well with this, I should say?
There's some states that are doing well. There's
rather not
states that are not doing well.
I got you.
We work closely with all of them.
Okay, well, very good. Thank you. That's all I have, Mr. Chairman.
Thank the ranking member, and I don't think we've got any other members on, so we'll go ahead and begin our second panel. We can make the transition now. I want to thank all of our first panelists for appearing here and also for their working collaboratively. All right, we'll now begin our second panel consisting of representatives from organizations who share our commitment to preventing veteran suicide. It's great to see you all. I wish our agency folks had stuck around to hear from you. Perhaps somebody from the respective agencies will at least be paying attention, watching this. We'll have the video available. We'll encourage them to do so because I think it's really important that we hear your perspectives and that frankly, they hear your perspectives. So first, and of course, all of you are here with organizations sharing our commitment in this hearing and always to do all we can to prevent veteran suicide. First joining us virtually from San Diego is Dr. Laura Ortiz-Miles, Senior Vice President for Mental Health Systems. Nice to see you. Thanks for joining us. Next, we have Mr. Nick Armstrong, Managing Director of Research and Data at the Syracuse University Institute for Military and Veteran Families. Thank you for joining us. Where are you? There you are. Hello. Next is Mr. Joy Elam, National Legislative Director for Disabled American Veterans. Thanks for being here. Next, we have Ms. Betsy Mercado, Co-founder and Executive Director for Objective Zero, joining us virtually. There you are. Good to see you this morning. Also joining us virtually is Ms. Judy Clausen, Deputy Chair of the Legislative Advocacy Committee for the National Law School Veterans Clinic Consortium. Thanks very much for joining us. And then finally, we have Ms. Emily DeVito, Associate Director of National Legislative Affairs for Veterans of Foreign Wars. Nice to see you again, Ms. DeVito. Thanks for joining us. With that, I'll now recognize Dr. Otis Miles for 5 minutes.
Chairman Levin, Ranking Member Moore, and distinguished members of the committee. On behalf of Mental Health Systems, thank you for the opportunity to present how Courage to Call is addressing the economic risk factors of suicide through a multifaceted, evidence-based approach working with service members, veterans, and their families across the full continuum of risk and wellness. With no single cause and no single solution, strategies to prevent suicide require collaboration of government agencies with community efforts at the local level. Courage to Call takes this upstream approach by delivering services that support economic opportunities and stability, including immediate crisis intervention and access to ongoing behavioral health care. The veteran population in San Diego County is well above that in California and in the nation. Almost 1 in every 10 adults in San Diego is a veteran of military service. According to San Diego's annual We All Count, as published by the Regional Task Force on Homelessness, 686 of homeless adults in 2022 were veterans, making up about 8% of San Diego's homeless population. With the passage of the Mental Health Services Act, MHSA, by California voters in 2004, the County of San Diego Health and Human Services Agency invested in prevention and early intervention. Courage to Call, a non-traditional program improving access to mental health services extending beyond those of the Department of Defense and Department of Veterans Affairs, was developed by Mental Health Systems in 2009 to provide confidential, peer-supported outreach and educational training services countywide to the veterans, active duty military, reservists, National Guard, and their families, community, and to providers of service to this community. With funding from Behavioral Health Services, Courage to Call continues to operate in alignment with the county's Live Well San Diego strategy, a long-term plan combining the efforts of partners both inside and outside county government to help all residents be healthy, safe, and thriving. Founded in 1978, Mental Health Systems, MHS, is a nonprofit organization based in San Diego with 80 broad-ranging programs and over 900 employees across 10 California counties. Our mission is to reduce disparities in behavioral health care delivery with a culturally competent, diverse workforce that promotes wellness, recovery, and resiliency. Courage to Call is led by MHS in collaborative partnership with 211 San Diego and Veterans Village of San Diego. Courage to Call is a resource for the resources, 100% veteran and military led, and operates via countywide outreach and education, a 24/7 peer line, as well as individual short-term prevention-oriented counseling. 211 San Diego provides a free 24-hour, 365 days a year confidential phone service in more than 200 languages. Our Courage to Call peer-to-peer navigators at 211 connect callers to accurate information in real time through a searchable online database of more than 6,000 services. The Community Information Exchange is also maintained by 211 with an integrated technology platform to deliver enhanced community care planning. This creates a shared longitudinal record of service delivery for veterans and shift from reactive approaches to proactive, holistic, person-centered care. Since serving veterans of all eras beginning in 1981, Veterans Village of San Diego, VVSD, continues to help our most vulnerable reclaim their lives through emergency, transitional, and permanent housing, mental health counseling, and substance use treatment. Our Courage to Call veteran peer outreach specialist makes direct linkages to VVSD's employment and training services to help veterans find new careers or resume previous career paths. Courage to Call outreach assists individuals with unique needs from LGBTQ+, women veterans, trauma-exposed, dishonorable discharges, and stressed families. Family members and loved ones who are concerned about the emotional health and well-being of those who have served are also eligible. This fiscal year, Courage to Call has served 935 individuals and 581 families. The program also serves community providers with training to improve military cultural awareness. Suicide prevention training is provided using the Question, Persuade, and Refer QPR method. This year, 180 outreach and education events have been provided. All Courage to Call team members provide a first contact resolution by ensuring that client needs are addressed to the best of their ability. Additional support for family members is provided by our family support partner. Regardless of the pathway of entry into services, veterans receive a biopsychosocial assessment and are immediately linked. For those needing enhanced care, veterans are connected to a veteran peer navigator. Throughout the COVID-19 pandemic, Courage to Call consistently provided services and at the San Diego Convention Center's homeless support, mitigating the negative effects of socialization and lack of service access. There are 80 individuals currently receiving counseling from our veteran peer navigators, 47 of whom expressed suicidal ideation and or suicide attempts this year. Other direct services include bi-monthly food distribution events in collaboration with Feeding San Diego, professional clothing closet access year-round, and annual Operation Dress Code events to provide business wardrobes to transitioning women veterans. In summary, reintegrating veterans into civilian communities requires a complex system of services ranging from outreach and engagement, transition, workforce reskilling, and care coordination to prevent suicide. The Courage to Call program is an active member of the San Diego Veterans Coalition and supports the Military, Veteran, and Family Transition Reintegration Project in alignment with the Transition Improvement Act of 2019 as introduced by Chairman Levin to prevent and relieve many stressors that can lead to behavioral, financial, and readjustment problems downrange and ultimately lead to a more vital and thriving life after military service. Thank you again. I'm available for questions should you have any.
Well, thank you, Dr. Otis Miles, and thank you for all the great work you do in San Diego and also for joining us virtually very early in the morning. I can relate often taking the 7:15 flight out of San Diego Airport, that it's an early morning out there, so we thank you. With that, I'll now recognize Mr. Armstrong for 5 minutes.
Good morning, Mr. Chairman, ranking member, members of the committee. I'd like to thank you for the opportunity to testify this morning. My name is Nick Armstrong. I served for 8 years in the United States Army, including nearly 3 years in Iraq, Afghanistan, and Bosnia with the 10th Mountain Division. From there, I attended Syracuse University as its first post-9/11 graduate student. Today, over a decade later, I continue to serve as managing director at the Daniel Institute for Veterans and Military Families. And all this is to say that today's topic is one that is both deeply personal and central to what we do at the IVMF. We understand the critical importance of economic stability, particularly in the first year after a veteran leaves the service. In fact, VA researchers now describe this time as the deadly gap when suicide risk is the greatest. And this is why we at the Daniello Institute are laser focused on delivering impactful programs and services that support those in transition on a national scale. With nearly 1/3 of the IVMF team of more than 100 staff located across the country, we are the nation's largest nonprofit provider of career training in small business and entrepreneurship education, supporting some 20,000 transitioning service members, veterans, and military spouses each year. I want to emphasize that reducing economic barriers to this programming is core to our philosophy, and consequently why all IVMF programs are offered at no charge and with no commitment of GI Bill or any other government benefits. And this has been possible in large part due to support of philanthropy. My written testimony is framed around 3 recommendations for how Congress and the federal government can better address economic risk factors by 1, expanding access to career training and credentialing offerings. 2, investing in cross-sector initiatives that improve resource navigation. And 3, empowering interagency and cross-sector data sharing. I'll touch on these briefly, beginning with how we prepare transitioning service members for their post-service careers. A high-quality job provides purpose, identity, and financial security, all protective factors to preventing suicide. For this reason, 7 years ago, the IVMF launched the Onward to Opportunity program, now the nation's largest DoD skill bridge offering, serving 11,000 a year, operating on 19 military installations and communities and online. Onward to Opportunity provides career exploration and employability skills training and access to industry-recognized learning pathways and credentials, again, at no cost. Yet today, demand for career training programs like Onward to Opportunity outpaces the supply. This creates inequities, and while philanthropy has been a great incubator of innovation, they don't support programs indefinitely. We applaud the recent passage of the Hannon Act and Staff Sergeant Fox Suicide Prevention Grant Program, as well as VA's expansion of its job training offerings throughout the pandemic. But new legislation like the Onward to Opportunity Act provides a chance to double down on VA's transition grants by expanding this access to career training offerings in underserved locations. Second, to address economic risks, we must continue to drive and support greater coordination of resources and care between government and the private and social sectors. Since 2015, through our America Serves initiative, the IVMF has assisted 18 communities to combine more than 1,000 health and human service providers and even VA and DoD facilities into coordinated networks of care. But more recently, the IVMF has come alongside our partners in the federal government in this regard. In my written testimony, I highlight 3 examples: the VA's ETS sponsorship program, the SBA's Community Navigator program, and DOL Vet's Employer Navigator pilot. Without a doubt, cross-sector pilot initiatives like these, those that pull together and integrate federal, state, and local community partners, are the future of transition support and hold the most promise to address economic risk factors to veteran suicide. Finally, our government has enormous amounts of administrative data. If harnessed more effectively and securely, these data give us the power to know how programs like TAP or the GI Bill are mitigating economic risks to suicide. New legislation introduced like the Secure Research Data Network Act would be a big leap in this direction. But cross-sector data sharing is just as critical. An example is a pilot initiative we started with the VA's Center for Health Equity Research and Promotion based in Pittsburgh. Data sharing between the VA and the IVMF's America Serves communities is allowing VA researchers to better understand gaps in how veterans are utilizing VA care and other local human services. To conclude, preventing veteran suicide is a whole-of-the-nation responsibility. Solutions, therefore, must include non-governmental partners. Today I've highlighted a few ways we can do that, and the government has an active, willing, and able partner in the IVMF. Thank you for the opportunity to share this with you all today, and I look forward to your questions.
Thank you, Mr. Armstrong. I now recognize Ms. Elam for 5 minutes.
Thank you, Chairman Levin, Ranking Member Moore, and members of the subcommittee. We appreciate DAV being able to testify today at this hearing to examine how to prevent veteran suicide by addressing known economic risk factors that can prevent mental health, that can affect mental health. Military life can be challenging and difficult, but it also provides stability, including a steady source of income, housing, and health care. Importantly, it also offers a sense of purpose and a community of support. However, for many service members, the transition out of military can be difficult as they try to replace and rebuild these foundations. Being prepared for the next stage of their lives by having a plan and utilizing resources is essential for a successful transition from military to civilian life. But for some, despite the best plans, unexpected challenges during transition can lead to emotional instability, particularly for those with post-deployment mental health challenges and service-related conditions. Financial strain and unanticipated loss of employment, lack of affordable housing, or access to health care can be overwhelming. Regrettably, these kinds of readjustment struggles cause too many veterans to suffer hopelessness and despair and without the tools and resources to cope, put them at risk for a downward spiral. Stories of veterans losing ground to these struggles, ultimately leading to suicide, is heartbreaking, and we must all do more to prevent such tragedies. We know that providing veterans with timely access to mental health care, appropriate resources and supports can make a real difference. Access to these crucial benefits and services can help vulnerable veterans weather times of psychological and financial crisis. The Transition Assistance Program, or TAP, was created to help make such transitions easier by offering vital information, resources, and tools for service members and their families to help prepare for the transition to civilian life before they leave the military. Unfortunately, some service members start the program just prior to discharge, not allowing them enough time to fully form their transition plans. Of course, the main foundation of financial stability and the key to most successful transitions is securing and maintaining gainful employment. It remains critical that VA, the Department of Labor, and other federal employment and training programs be fully funded and that Congress continue to seek innovative ways to improve these programs. We also must continue efforts to make it easier for veterans to translate and transfer job skills and training from their military service to the civilian workforce by addressing barriers to state certification and training requirements. DAV has developed our own multifaceted employment program to help connect veterans with jobs and meaningful careers. In partnership with Recruit Military, DAV hosts employment seminars around the country for transitioning military members, veterans, and their spouses. Last year, DAV hosted 82 traditional or virtual career fairs with over 19,000 attendees, resulting in nearly 6,700 job offers to veterans or their spouses. DAV's National Service and Transition Service programs also offer economic support to veterans, particularly during transition, by helping them secure federal benefits they have earned through their service, including disability compensation for service-connected injuries and illnesses. Awards of service connection are a gateway to VA healthcare, including mental health services and other programs such as VA's Veterans Readiness and Employment, or VRE program. Another critical way to help transitioning and former service members is providing them with a renewed sense of community and purpose, which many veterans lose after military service. DAV offers veterans a myriad of opportunities to find fellowship, social connections, and renewed purpose through our membership and volunteer programs. Volunteering to assist sick and disabled veterans at VA facilities or providing veterans rides to their VA medical appointments not only support veterans in need, but provide a critical connection and purpose for thousands of veterans who might be at risk for suicide. For our most seriously injured veterans, participation in sports rehabilitation events like the National Disabled Veterans Winter Sports Clinic, co-hosted by VA and DoD, help veterans rebuild their lives and see what is possible, providing hope for a meaningful life and future. Mr. Chairman, DAV is committed to continuing our efforts to help strengthen veterans' economic and social foundations, and we look forward to working with you and other members of the subcommittee to explore additional ways to achieve that goal. That concludes my statement, and I appreciate the opportunity to be here and to answer any questions your committee members may have.
Thank you, Ms. Elam. I now recognize Ms. Mercado for 5 minutes.
Good morning, Chairman Levin, Ranking Member Moore, and members of the subcommittee. I am grateful for the opportunity to discuss the importance of upstream approaches that address economic risk factors in an effort to reduce veteran suicide. I am Betsy Mercado, a military spouse and executive director of the Objective Zero Foundation. We are a tech nonprofit with the mission of connecting the military and veteran community to mental health and wellness resources and to a network of peer support to prevent suicide through wireless technology. We've supported 20,000 service members, veterans, family members, and caregivers that have downloaded the Objective Zero app with evidence-based and informed tools, training, and resources, mitigating many of the risk factors associated with suicide in our community. President Biden's strategy to reduce veteran suicide outlines several priorities that align with Objective's own mission and focus. I would like to amplify 3 potential paths that can help reduce veteran suicide that address economic risk factors. First, Leveraging technology and the upstream approaches of this strategy can boost its effectiveness. Technology, particularly wireless technology, can be a bridge over otherwise impassable barriers for our veterans. Technology allows us to reach veterans where they are, facilitating connections to telehealth, peer support, and a range of resources to build the skills and support to overcome whatever challenges they may experience. Second, instrumental to President's strategy is the implementation of policies and programs that promote economic well-being as an upstream protective factor. Objective Zero has been able to support homeless and low-income veterans, getting them connected to stable housing and employment opportunities. We've also supported veterans and their spouses after their transition out of the military, navigating resources and being a listening ear. The greater access to technology, the greater probability that veterans can access the resources they need when they need them. I also want to underscore the importance of thinking more holistically about this problem and potential solutions, specifically the underlying economic instability of military and veteran families. Debt, underemployment, unemployment, homelessness, and food insecurity are but some of the economic risk factors that we've seen our community members experiencing. Many of the issues that our service members and families experience may be exacerbated during and after a transition out of the military. Any policy solution must address underemployment and unemployment of military spouses due to the unpredictability of the service member's career as another upstream approach. These same job opportunities should be available for the spouses of transitioning service members and veterans. And third, cooperation and collaboration in public-private partnerships will ultimately be the decisive factor in whether the strategy succeeds or fails. If veteran suicide could be solved by one person or organization, it would have been done already. We will accomplish more through cooperation and collaboration than through siloed efforts. Public-private partnerships leverage the power of diversity of approaches while balancing the need for unity of effort. Many of the people working in this space have the experience and perspective in overcoming many of the challenges that our service members, veterans, and their families face and want to be part of the solution. Before a man or woman holds the title veteran, they were first a soldier or sailor, airman or Marine, coastie or guardian. Consequently, any approach that is upstream of the veteran must account for the fact they were first a service member, and these upstream approaches must by necessity link public and private agencies to help mitigate the transition between active service into civilian life for both the veteran and the family. An upstream approach to veteran suicide prevention starts while a person is still in uniform. I would like to conclude by saying, when thinking about the causes of veteran suicide, it's important to remember that there is no single cause, but rather a series of variables which can lead someone to suicide. This underscores the importance of leveraging wireless technology and upstream approaches, greater access to resources, and collaboration between government agencies and nonprofits to address risk factors. When we are providing evidence-based programs and services and working together, we will continue to reduce the rate of veteran suicide. I appreciate the opportunity to testify and will take any questions you may have.
Thank you, Ms. Mercado. I now recognize Ms. Clausen for 5 minutes.
Thank you. Chairman Levin, Ranking Member Moore, and distinguished members of the subcommittee, on behalf of the National Law School Veterans Clinic Consortium, thank you for inviting me today to discuss how our clinics address upstream risks of veteran suicide. Upstream risks include financial strain, lack of housing, food insecurity, unemployment, and legal issues. We at our clinics give veterans hope. Today, I'll outline our practice areas and I'll show how we address upstream risks. I'll conclude with a few reform ideas. First, we help veterans obtain VA benefits, and this addresses financial insecurity. Collectively, we have recovered tens of millions of dollars of wrongfully denied VA benefits. And to illustrate how this addresses upstream risks for an individual veteran, one of our clinics recovered hundreds of thousands of dollars of retroactive benefits for a homeless Vietnam veteran, enabling him to buy his first home. Our services are pro bono and many of us fund clients' expenses with Equal Access to Justice Act fees. This provides veterans access to medical experts, and this helps veterans prove their cases. But even if they ultimately succeed, veterans often wait years for their decisions. These delays cause a feeling of powerlessness. Plus, to support mental health claims, veterans must relive trauma in exams, VA hearings, and written testimony. This process exacerbates mental health symptoms. One veteran stated after her VA hearing that she struggled to get out of bed for days. Second, in discharge upgrades and character of discharge matters, we help veterans obtain financial security and we remove employment barriers. Because of limited employment prospects, the trauma from forced separation, and denial of access to VA benefits, veterans with other than honorable discharge may be at greater risk of homelessness and suicide. When we obtain a discharge upgrade, we remove stigma, expand employment prospects, open access to VA benefits, and help veterans regain self-esteem. However, here, veterans often wait years for decisions, and these delays exacerbate their stress. Plus, when they receive those decisions, they are often denials with little analysis. This leaves veterans feeling abandoned. We made systemic change here. Yale convinced the Navy to review certain discharges of thousands of veterans with mental health conditions, potentially removing employment barriers and providing access to VA benefits. Third, interactions with the criminal justice system leave veterans at risk of suicide and homelessness. Some of our clinics address these upstream risks when they represent veterans in Veterans Treatment Court. Completion of the program enables shorter probation or even avoiding a criminal record, and a clean record preserves employment prospects. Fourth, some of our clinics provide Know Your Rights presentations and direct legal representation concerning general legal aid matters such as family law, consumer debt, landlord-tenant, criminal records expungement, driver's license reinstatement, Social Security, wills, guardianship, advanced healthcare planning, and small claims. These services are vital to veterans at risk of homelessness. For example, one of our clinics obtained a release from the lease of an apartment filled with mold, and this allowed a disabled veteran to move to safe housing. My written testimony explores several ideas for reforms. Today, I will highlight two. First, for the most part, we created the infrastructure of law school clinics without federal funding. If Congress wants to jumpstart other vital legal services, consider grants for small business clinics. Law students could create business entities, draft governing documents, and obtain intellectual property protection for veteran entrepreneurs. Law students could partner with business school students who could develop business plans and marketing strategies. These services could help veteran entrepreneurs regain the sense of purpose they had when serving. Plus, veteran-owned businesses would be likely to hire veterans. Second, investigate expanding the GI Bill to veterans with general discharges. One case serves as an example. A medic who had back-to-back deployments to Iraq self-medicated his PTSD with drugs. This led to an other than honorable discharge. He obtained an upgrade to general, but he still doesn't have access to the GI Bill. He has to take out educational loans to pay for his schooling. Expanding access to the GI Bill will address upstream risks. We want to help you address these risks of veteran suicide, and we're happy to take on research projects to help. I welcome your questions.
Thank you, Ms. Clausen. I'll now recognize Ms. DeVito for 5 minutes.
Chairman Levin, Ranking Member Moore, and members of the subcommittee, on behalf of the men and women of the Veterans of Foreign Wars of the United States and its auxiliary, thank you for the opportunity to provide our remarks on this important topic. Veteran suicide prevention is a complex and multifaceted initiative. The VFW firmly believes addressing protective factors, including socioeconomic elements, can mitigate upstream risk before mental health reaches a critical juncture. This is why VFW works with partners like PsychArmor, GivenHour, and Humana to focus VFW service officer training on identifying social determinants of health and intervening with veterans as necessary. We firmly believe that as we better equip our local advocates to take upstream action, we are mitigating suicide. While VA's annual suicide report provides data correlating veteran suicide and VHA encounters, this report falls far short of comprehensive and does not address data related to veterans in programs administered by VBA. The VFW insists VA stop tracking only VHA encounters and track VBA data as well. VA must integrate this data starting from when a service member transitions, as we believe this will help combat suicide. Transition from active duty can set the stage for long-term financial and economic well-being. It also marks a time veterans face one of the highest risks of suicide as they undergo significant changes, including changes in financial stability. VFW's Benefits Delivery at Discharge, or BDD representatives, embedded within the TAP program, note many transitioning service members do not connect with VA services at this critical juncture. Additionally, BDD transition surveys find only 60% of respondents typically report participating in the TAP tracks that provide tailored instruction related to employment, vocational training, and education. Congress must provide oversight to ensure service members are adequately introduced to these benefits at transition, and also require reporting on the success of VA's Solid Start program. Education and employment are critical protective factors to suicide mitigation, and both can set veterans on a path for long-term, stable housing and food security. Education and employment can also give veterans a sense of purpose and provide opportunities to connect with new communities and engage with resources, such as VA's VITAL program. On campuses with VITAL programs, veterans can access VA mental health care on-site, and university staff can receive VA training to better work with student veterans to identify mental health risks. VFW urges Congress to expand resources for programs such as VITAL, as well as extend authority for VA to allow all student veterans access to community vet centers, another critical resource for mental health care. In current economic and housing conditions, even employed veterans face housing insecurity and may struggle to put food on their tables. With homelessness posing a significant upstream risk to suicide among veterans, VFW strongly urges Congress to pass legislation that will resource and expand GPD, SSVF, and HUD-VASH programs. Food insecurity has strong ties to upstream risk for veteran suicide. Recent studies find veterans are less likely to participate in food assistance programs like SNAP, despite being more likely to face insecurity than non-veterans. Disabled veterans are at significantly higher risk of food insecurity, with many reporting VA disability compensation is precluding them from food assistance programs. Congress must pass the Feed Hungry Veterans Act, which would expand SNAP eligibility to veterans in desperate need. Many veterans discharged under Don't Ask, Don't Tell, or with a diagnosed mental health condition have for too long been barred from critical government economic opportunity benefits, including GI Bill and VA guaranteed home loans, due to the less than honorable nature of their discharge. Congress must provide oversight to DoD and VA to ensure adequate outreach is conducted to veterans deserving upgrades, and those upgrades are timely and minimal burden to those veterans. The VFW believes every time a veteran uses a VBA program, it is an opportunity to provide resources and communication. Among the 17.2 veteran suicides per day, 10.4 involve veterans with no recent VHA interactions. We have no data correlating VBA interactions. VBA cannot rely on VHA data and access alone to defeat suicide. We need not only research and data on veterans using economic opportunity benefits, but we must also encourage veterans to engage with these earned benefits and provide those resources when they do engage. VFW stands by ready to work with you to ensure a way forward towards the collective mission to end veteran suicide once and for all. Chairman Levin, Ranking Member Moore, this concludes my testimony. Thank you for the opportunity to provide our remarks. We look forward to engaging in further discussions on this subject.
Thank you very much, Ms. DeVito. With that, I'll recognize myself for 5 minutes to begin the question portion of the hearing. Dr. Otis Miles, thank you for joining us remotely from San Diego this morning. I really appreciate the work that mental health systems encourage to call do to serve veterans across our region. It was interesting to hear how integrated Courage to Call is with its wide array of community partners, from providing food resources to peer support. The collaborative model that you've built is really impressive. Can you talk us through the importance of this integration to ensuring that veterans are able to easily access resources so they don't fall through the cracks, as frequently can happen in a disjointed system?
Absolutely, and that's a strategic question in terms of how to address veterans and their families at risk through collaborative partnerships within the community. I appreciate your feedback about Courage to Call and our work in collaborative partnership with 211 San Diego and Veterans Village of San Diego. But as I mentioned in my testimony, we're also actively engaged in the San Diego Veterans Coalition, which is a large membership here in the community of public and private partners involved in serving veterans and active duty military and their family members. Through the integration of the partners within the community, we have a common ground and goals related to supporting those that are most vulnerable, those who are going unserved or underserved. The testimony today has identified several, high-risk target populations, with those that are transitioning with economic instability related to employment and access to benefits being at most at risk. And the collaborative partnership through the San Diego Veterans Coalition and the work that we're doing at Courage to Call is highlighting the success of that partnership. There's regular meetings, there's strategic positioning with our local government and other entities to be able to continue to collaborate and target those most vulnerable and at highest risk. And our commitment is to continue to do that in the San Diego community and provide a model for support in other communities looking to form a veterans coalition modeled after San Diego and our efforts at Courage to Call as well.
Thank you for that. You know, our agency representatives that were on the last panel unfortunately did not stick around to hear from our VSOs, which I wish they had. We'll make sure, hopefully committee staff can send them the link to this video, which I know will be archived. So with that in mind, the question for you, Dr. Otis Miles, is if they were here, if they were sitting here listening to you, what would you recommend to them as best practices to collaborate in this shared goal of preventing veteran suicide?
Another strategic and important question for me to respond today in what I would recommend to our governmental partners. What comes to mind first for me is willingness to engage and allow access for community-based organizations at the local level to participate in their work and be included and relied upon to reach veterans and active duty military and those most at risk, including their family members. I think that for our work at Courage to Call, where we've made an impact is engaging family members and loved ones. As we know, with the VA and other services targeting the veterans specifically, Courage to Call has been able to make an impact on improving access to services through family members and loved ones, which provides that additional support to be able to mitigate a risk of suicide through, early intervention and prevention. And I would recommend to our partners at the VA that we continue to remember and strategize our efforts focused on access to care for the family members and loved ones and continue to collaborate in that manner.
Well, thank you very much for that response, for your continued work and the collaborative model that you employ in our region. I'm going to have a couple more questions, but I will break for the ranking member, and I also see Representative Cherfilus McCormick. So we'll go to the ranking member for his questions.
Ms. DeVito, can you please tell us more about how you believe the two-day optional tracks related to employment, small business, and education could benefit service members and improve economic well-being? I understand that for some service members, these tracks are still optional, and should that be changed?
Thank you for that question. We have been very pleased with some of the changes that started a few years ago, from adjustments that were made to TAP to make it a more tailored experience, including family members. We think that focus on spouse employment is really crucial towards financial stability. But in those changes, giving that tailored individual assessment allows the specific service member to be placed in a tier that does make those tracks now optional. What we don't know and we don't have data for is does that have negative consequences and negative impacts? And because we are seeing lower than we would expect numbers from our surveys at VFW from our BDD reps, we want there to be oversight and data that can show if there are negative consequences, and if so, what changes need to be made.
Okay, thank you. Also, in your written statement, you commented that the VA needs to do a better job communicating suicide mitigation strategies with veterans when providing bad news from VBA. Can you please expand on that?
Yes, absolutely. For an example that I shared in my written statement, a member had shared when he was receiving overpayments from GI Bill and VR&E use. He received a vague debt letter from VA that he was confused based on his debt, and it also included suicide resources. So while that was a really great touch point to reach that veteran, it was really jarring for that veteran when he wasn't receiving adequate communication for his debt. So what we just really encourage is we want that these touch points to be leveraged as much as possible, but it needs to be intentional. It needs to be done with feedback from the veterans if that is helpful information for them. It needs to include data on whether or not they're using the resources being provided to them, and just integrating feedback to the veteran and not being a check in the box from VA or whichever government entity is providing that resource.
Okay, thank you. And with that, Mr. Chairman, I'll yield back.
I thank the ranking member, and I'd like to recognize my friend from Florida, Representative Cherfilus McCormick, for her questions.
Thank you so much, Mr. Chairman. My question is for Ms. Marchiato. Thank you for your detailed testimony regarding the Operation Zero and your organization's commitment to reducing veteran suicide. I appreciate you highlighting the key point that everyone has a role in ensuring veterans are getting the care and resources they need during the time of crisis. Collaboration between public and private sectors are vital to meet our end goal. But I know that in many instances, working with large government bureaucracies can be cumbersome and difficult. Do you have any suggestions on how the federal agencies represented here today could better collaborate with and utilize the services and resources non-governmental organizations have developed to address veteran suicide?
Absolutely. Thank you so much for your question. I think the first point is just the ability to have those community partnerships. For example, we are a community partner of the VA, and it took over 18 months just to go through that process to become a community partner. And so I think one way is to shorten those times so that more organizations like Objective Zero, which is a small organization, can be a resource to the VA and other government organizations, because we know so many veterans are not using their services. So other resources like Objective Zero are vital to get people connected to resources to prevent suicide.
And would you happen to know of any reasons why they're not using their resources? Are there any obstacles that we can actually take affirmative steps towards removing?
For us, in our experience, a lot of it has to do with trust. Many veterans don't trust the government, for example, so they rely on other organizations. Some don't feel like they deserve the benefits that the VA offers, or they do not qualify for them. So I think part of it is understanding what benefits are available to veterans, and also allowing family members to be more part of the process and understanding the benefits of the veteran as well.
Thank you so much, Mr. Chairman. I will yield back.
Thank you very much. I'll conclude with a couple of questions Mr. Armstrong, I want to drill into a statistic from your written testimony that really stuck with me. And I quote, "The most recent available data suggests DoD spends more on unemployment insurance claims for unemployed transitioning service members, almost $300 million, than it does on all career transition programs." Think about that. It just makes no sense. It's staggering. How could the Department of Defense better allocate their resources to invest in the post-military futures of service members and their families?
Thank you so much for that question, Chairman. One of the pieces of legislation that we put forth in the written testimony is the Armed Opportunity Act. Of course, DoD helps deliver the Interagency Transition Assistance Program. And of course, this is available to every service member as they exit the service. But even with the elective tracks, we know from both the data we collect, the research we've collected through studies, and also the programs that we deliver, that there is still a demand for additional training programs post-service, particularly when it comes to career transition. And so being able to deliver and expand and build out partnerships through the DoD Skill Bridge Authority, particularly when it comes to career training and offerings of not just for those that are in transition, but particularly in that year post-transition, of being able to provide greater access, and also not just on the handful of installations that these programs are delivered on, but even to the National Guard and Reserve and others that may not have access to those training offerings that are located on larger installations where we are offered, for example.
So it would follow that if DoD is spending more on unemployment insurance for unemployed transitioning service members than they are on the entirety of all career transition programs, this is a real problem. Wouldn't you agree with that?
I would, Mr. Chairman.
How does the failure to prepare service members for a post-military career increase the likelihood that they may experience a suicidal crisis?
Thank you for that question as well. We know through research, not just that we collect, but with even the VA itself and other researchers, that some of the biggest predictors of suicide are related to financial security, housing, and other types of social needs. And so what we do at the IVMF in terms of not just career training, but also working with communities to knit together social services and providing greater access to those upstream needs, are ways that we can further prevent folks falling into crisis, and actually providing more of those access to those programmings upstream for those in transition. I mentioned the ETS sponsorship program that we're piloting, that VA is piloting, and we're helping to support, of helping to enroll folks in peer support programs even before they take the uniform off. I think programs like that are really key to helping to prevent veteran suicide, and helping folks actually thrive post-service and not find themselves in crisis.
Thank you. Thank you for that. Ms. DeVito, I'll turn to you. I want to thank you for your detailed testimony and for everything VFW does on veteran suicide, and we appreciate the opportunity to continue to work with you. One important thread we've heard is about data integration. I was especially compelled by hearing that though VA plans to do so this year, prior VA National Annual Reports on Suicide Prevention did not integrate VBA data. Can you discuss why this data is immensely important to our understanding of a veteran's risk for suicide?
Absolutely, Chairman. Thank you so much for that question, because we really cannot emphasize enough how critical VBA data is to a path towards suicide mitigation. VFW has also received the verbal confirmation of sorts from VA that with the intent to include this data in follow-on reports, but we do still feel that there needs to be a codifying of that requirement. We look at fiscal year 2020, the top 3 VA programs by use were disability compensation, healthcare, and education programs. 2 of those 3 are administered by VBA. In that fiscal year, there were close to 1 million veterans participating in GI Bill and VRNE, and to date, we have not correlated that available data to see if there is a correlation to suicide mitigation. So we just really strongly feel that it needs to happen quickly, and it needs to be a requirement.
Well, I wish they were here to hear you, but again, we will share the link with our friends at the agencies and ask that they follow up. Beyond VBA data, is there additional information VA could be collecting on a veteran's financial situation or their social determinants of health that you think could further inform their analysis of risk factors for veteran suicide?
We really think the first step is making sure that every time VBA is leveraging a program or someone is engaging in a program, that is a touch point. And again, the first step even to that is making sure that veterans are connecting to those programs in the first place, because education will lead to employment, that will lead to housing and food security. And if there's any step along that way that's missed, it's just going to increase risk. So we really think every time there's an opportunity to touch a veteran is an opportunity to communicate.
Thank you for that, and I thank all 6 of you for all the work that you're doing to prevent veteran suicide. Turn to the ranking member. Any additional questions?
Thank you, Mr. Chairman. Mr. Armstrong, what is your view of the services that are provided by the Disabled Veteran Outreach Program specialists and local veteran employment representatives at American Job Centers? Do you find the employers prefer to work with these state employees or your employer navigator program?
Ranking member, thank you for that question. I can't speak specifically to some of those state agencies other than those knowing that many of them are providers within some of the community networks that we've provided technical assistance to. On the Employer Navigator pilot, we were just onboarded to that program with DOL vets a few weeks ago. We just started receiving our first few referrals, so are very optimistic about that pilot and being able to serve more of those that are in transition. On our side with the Opportunity Program, most of the employer partners we have, though, are private sector with a handful of government agencies as well. Thank you.
Thank you. Ms. Mercado, you said something earlier in one of your statements I found interesting. You said that the veterans don't trust government. I understand you're related to veterans, and I have a few in my family as well, but why is that, and how would we improve on that? What are your suggestions?
That's a great question. That's often the feedback that we receive, why people are reaching out to Objective Zero for support. The trust factor, I mean, it's for a variety of reasons. Maybe they had a poor experience, or someone they served with had a poor experience with the VA or other government services, and so they just don't want to use it. And so I think that's so important for us to have a variety of resources available to the veteran community. And do you mind repeating that second part of your question, please?
Well, I was just curious to how you thought we might improve. I can understand sometimes why we have a lack of trust in government. I think sometimes that's healthy in a lot of ways, but at the same time, I wanted to know what your thoughts on how we improve. How do we make veterans feel free to reach out to the VA, to reach out to us for help when they need it?
I think that's where peer support comes into play. We are the foundation that is peer support. And so when community members are reaching out to our peer support through the Objective Zero app, we're encouraging them to seek the VA benefits because they've earned them. And so we try and get our users that aren't currently enrolled in VA services into the VA. If not, we provide other resources that help with whatever issue that they're experiencing. But I do think peer support is such a vital tool in encouraging people to get support using VA services.
Yeah, I like the idea of peer support. I would like to see, and I think all of our agencies and organizations could have maybe members who have had good results, who have had successful stories, to share those, make them public, put them out in publications so that at some point they read their peers going, hey, I had a good experience at the VA, or whatever agency group, whatever VSO, whoever they reached out to. And I think if we can start encouraging members to share personal testimony. I think that builds more credibility a lot of times than what we can try to sell here on the Hill. So that was just, I was curious to how we build that trust in government and these agencies, and so these veterans are not afraid. And we have to be careful what we pass here on the Hill. I get that. I mean, that creates some issues for our veterans. Sometimes they don't trust us, and I get that. I mean, but we really want to help them, and I think it's good if we could do peer-to-peer where we share testimony. But with that, Mr. Chairman, I'll yield back. Thank you.
Thank the ranking member. If there are no further questions, we can bring this hearing to a close. I thank our witnesses again who have joined us today. All members will have 5 legislative days to revise and extend their remarks and include additional materials. Without objection, the subcommittee stands adjourned.